My name is David Belk. I have an independent practice in the San Francisco Bay Area in Alameda, California. For the last, 9 years or so, I've been trying to untangle healthcare costs almost sort of in a microwave way in terms of, untangling the cost of everything in healthcare. And I started this website called truecostofhealthcare.org, which now contains really hundreds and hundreds of financial documents, among other things, from all the various industries within healthcare. The 10K financial documents from the pharmaceutical companies, pharmacies, hospital records, lots of stuff like that. And over the last 3 years, I wrote a book based on what I found, called The Great American Healthcare Scam: How Kickbacks, Collusion, and Propaganda Have Exploded Healthcare Costs in the United States. So as you can see, most of what I found, hasn't sat well with me. All right. And so tonight I'm going to present some of what I've written in that book. It's going to be a relatively short presentation, so I'm going to go rather quickly here. All right. So to start with, I think we all know we in the United States pay far more than most other countries for our health care. I mean, that's kind of a given with this crowd, I'm sure of that. And we also know that for all the money we spend on health care, our outcomes aren't that great, meaning that we pay more and get less, or in another way, we are overcharged. And so what I've been trying to get to the bottom is, who has been overcharging us and how have they been getting away with it? All right. And so I'm going to present this in, well, two parts really. The first, I'm going to present prescription medications and medical billing. I'm not going to have time to talk about the health insurance companies tonight. That's going to have to be postponed for another discussion. But I think I'll give you enough here to at least surprise even among the most jaded among you. All right. And I will start with the curious case of Patricia Bernstein. Now, Patricia Bernstein is a patient of mine. She suffers from migraine headaches. She's had them since she was 12 years old. They can be severe. Fortunately for her, her migraines are often controlled by a medication called Maxalt. Even more fortunately, Maxalt has been generic since 2013. Now, in September of 2015, 2 years after Maxalt went generic as rizatriptan, I wrote Patricia a prescription for 40 generic rizatriptan. All right. She went to the local Walgreens with her insurance, and about an hour later, I got from the fax machine this rejection notice. And you can see on the bottom there, near the bottom, message: plan does not cover this medication. All right. So they said, we don't cover the generic rizatriptan. And not only that, she got them to quote a cash price for her if she decided to just buy it herself. And here you can see $1,489.99, almost $1,500 for the 40 pills is what they told her it would cost if she paid cash. All right, so I went through the trouble of authorizing it. I got the insurance company to reconsider. They did. They said, okay, we'll cover her rizatriptan. She goes back to Walgreens the next day. They tell her, well, it's going to be $168 and you can only buy 10 pills for that. Her copay for the covered rizatriptan was $168 for 10 pills, or $17 a pill, less than the $37 a pill they originally quoted her. I told her, forget about Walgreens, forget about your insurance. Go down the street to the local Costco and tell them you don't have insurance, okay? Costco, not Canada, Costco. And here's her receipt. She bought all 40 10 milligram rizatriptan pills for a cash price of $41.21, or $1.03 per pill. So to recap, Walgreens quotes her $37 a pill, cash. With her insurance, it's $16.87 a pill. Without her insurance at the local Costco, it's $1.03 a pill. What's going on? All right. Well, this is actually something I see in my office every day, and I've been seeing it for many, many years. This is an extreme example. Usually what happens is someone comes to my office and they say, for a new patient appointment, and I ask them if they're on any medications. They might say, well, I take amlodipine for blood pressure. I'll always ask, how much do you pay for that amlodipine? and they'll say something along the lines of, oh, hey, I have really good insurance. It's only $10 a month. Really? And then I show them this receipt here. Okay, this is from 2016. They got this a patient of mine who bought 365 generic amlodipine for $19.08 at Costco. All right, that's not only not uncommon, it's actually the rule. And this brings me to what I think is the most poisonous myth in healthcare today. The myth is, oh, and here, is GoodRx website, where you can also show them. I just got this on Saturday, right? Amlodipine generic, you can buy it at Safeway for $16.76, which means the price has gone down since 2016, and Costco sells it for $17.78. 365 tablets, a tablet a day for a year, okay? Literally pennies a pill, all right? And again, the myth. The myth in the United States is that all or nearly all prescription drugs sold in the United States are really expensive. The reality is that about 87% of prescriptions filled since 2017 were for generic medications, and most generic medications cost pharmacies pennies per dose. That's how much the pharmacies pay for them. And not knowing this means you'll never suspect when you're being overcharged. And this is a recurrent theme throughout the night. Not knowing when a medical product or service is really inexpensive means you have no way of knowing when you're being overcharged. And it happens very often, all right? Now, another thing people aren't aware of, brand name medications don't cost 2 or 3 times as much on average as generic medications. Most brand name medications cost an average of 100 times the price of their generic equivalents, even when it's the exact same medication, okay? And I know this because, about every month I go over what's called the National Average Drug Acquisition Cost. This is, CMS since 2012 has been tracking what pharmacies pay for every medication they purchase every single week, okay? How much they pay for all of the medications. And, you can go online, National Average Drug Acquisition Cost, and find out exactly what they pay for each and every medication. And I'll give you some examples here, okay? So this is just 5 pills that, I picked at random. I could have done it with 50, but, So Abilify, it's a psychiatric medication. The brand name Abilify costs pharmacies an average of over $40 a pill. The generic, aripiprazole, 36 cents. The difference 113 times. Lexapro, another psychiatric medication, $12 a pill for the brand name, 8.7 cents a pill.
Wow.
Generic. Lipitor, $15 a pill, 8.7 cents for the generic. Norvasc, $9 for the brand name, 2 cents for the generic, and so on. Down to the bottom, Diovan, which is only 23 times the price of the generic. That's almost the low end of normal. I once went over a list of over 100 medications. The average price difference was 87 to 1. All right, and you can see, again, GoodRx prices. It gives me a good track for what you can get these medications for if you ask, if you know how to ask and whom. All right. So, for example, the generic Abilify, aripiprazole, you can get 100 pills for $44.25 at Costco, whereas the brand name costs over $4,000. The generic Lexapro, $12.33. Brand name Lexapro, $1,200. Generic Lipitor, $12.39 for 100 pills, cash. $1,500 for the brand name, okay? If you really want a brand name medication, or you need a brand name medication because there's no generic equivalent, yeah, it's going to cost you. But again, 7 out of 8 prescriptions filled in this country are for generic medication, the vast majority of which cost pennies per dose, literally, all right? So why do we have this myth? Well, I do tend to blame the news media for this somewhat. They're biased towards sensationalism, and the sensationalistic stories are the ones about the incredibly expensive brand name medications. So that's all they talk about. That's all you ever hear about, right? Well, if half truth is a great lie, what's 1/8 of the truth? And that's the real problem. Nobody is ever told, and even when they mention generic medications, they usually misquote the prices by, large amounts. They almost never give you an idea of just how much less expensive they truly are and how affordable they truly can be. But the other reason is history, right? We couldn't have this discussion even 2 decades ago because, you know, if you look at the proportion of prescriptions filled that are generic, even, you know, as recently as 2000, if a doctor wrote a prescription, it was, you know, 3 in 5 chance it was for a was for a brand name medication and therefore very expensive. However, in recent years, generics have become so ubiquitous that, you know, I often have patients, it's very common for me to have patients who are on no brand name medications at all. And I often tell them, look, you'll save a lot of money if you don't use your insurance to purchase your medications. And the other reason you don't hear about this has a lot to do with what are called the pharmacy benefit managers. They're not talked about a lot, and they should be, because pharmacy benefit managers, among the things that they did was they forced most pharmacies to sign gag orders. All right. In other words, they're not allowed to talk about the price of the actual prices of their medications, even if they want to, with any of their customers or anyone else for that matter. All right. And this is one of the reasons so little has been known about these prices. All right. They mostly got off the ground in the late 80s. The pharmacy benefit managers were originally, you know, created to determine the cost effectiveness of medications. Most medications then were brand name. And so, you know, determining which medication provided the best bang for the buck was relevant back then. However, their purpose of the pharmacy benefit managers has changed very dramatically. Since most medications now are generic, determining the cost effectiveness of a 5-cent pill versus a 7-cent pill is kind of a waste of time. So instead, what they did was, to stay relevant, they forced the pharmacies to sign the gag orders. And also they used kind of a carrot stick approach where they said, look, sign the gag orders and play by our rules, or we won't let any of the people who are insured through us shop at your pharmacy. So they pretty much threatened to cut off any pharmacy that didn't play along. And since most pharmacies couldn't afford this, they have all been playing along. And, you know, what's more, when they do talk about prices, what they usually give is what's called a list price. Okay, so here's an example of a typical list price quoted by a pharmacy if you don't mention the free discount or you don't mention insurance. If you call up Lucky Pharmacy, it's here, it says for generic atorvastatin, 100 pills. If you call up Lucky Pharmacy and mention a GoodRx coupon, it's $12.39. But if you don't, they'll say $595. This was the $1,500 that Patricia Bernstein was first quoted for her medication when her insurance denied her. So you can see list prices, which are the most commonly talked about prices, have nothing to do with actual costs of medications. And, you know, so I made this table, you know, comparing list prices, NADEC price, what the pharmacy pays, and lowest GoodRx prices. I made this about 2 years ago for about 10 different medications. Atorvastatin, the average list price for Safeway, Walgreens, CVS, Target, $341 for 90 pills versus $7.25 was what they bought it for. And the lowest cash price was like $11 and so on. Okay. And you can see throughout this, I mean, you know, olanzapine, generic Zyprexa, over $1,000 for $15 worth of pills. This is common. This is really the rule. Most of the time, these medications cost pennies a dose, but most of the time you can't find that out unless you know where to shop and what to say. All right. And the other thing is that the copay that you pay for these medications when they're generic not only is more than the cost of the medication, more often than not, when you're buying a generic medication, the pharmacy doesn't keep the entire copay. 23% of the time, they split the copay with the very pharmacy benefit manager that determined the copay. So not only do you pay $10 for a month's supply of blood pressure pills that cost the pharmacy 60 cents, the pharmacy splits that $10 like 50-50 with the very entity that determined that you should overpay for it, right? So, I mean, it's called a clawback, and it sounds really corrupt because obviously it is, but it's also perfectly legal, all right? And so you can see the three main pharmacy benefit managers in the United States: OptumRx, Caremark, and Express Scripts. This is their revenue growth between 2006 and 2017. You can see they've been skyrocketing in spite of the increase in generic medications, which ought to have made them less necessary. They have been going up and up and up in their revenue, all right? Largely because of Medicare Part D, but also because, well, of their tactics. Now, obviously that applies to the 7 out of 8 medications that are generic. But if you do need a brand name medication, oh, are they expensive? Why are they so expensive? 2 reasons: pharmaceutical companies and pharmacy benefit managers. Now, I think most of you know about the pharmaceutical companies, of course. Massive profits, spend a lot of the money on marketing. They talk about the research, but the research never, for most of them, is never as much as either the profits or the marketing costs. But between 2012 and 2016, the average price of brand name medications increased over 70%, okay, which was 14 times the rate of inflation, which is pretty astounding since they were expensive to begin with, okay? And what's even more astounding is that this particular inflation occurred for brand name medications, whether or not there was a generic equivalent. Here are some examples, all right? This is for Advir, okay? It was about $3.80 a dose in 2012. It's well over $6 a dose by 2018. Lantus insulin, same thing. You have, it more than doubled in price over that 6 years. But here you have Lexapro, right? The price of brand name Lexapro went from $4.50 a dose to almost $12 a dose by 2018, even though the generic was easily available for pennies per dose. And Lipitor, the same thing, skyrocketing in price in spite of a generic equivalent. Okay, what's going on? Rebates. Okay. Most of the price increases on these drugs, believe it or not, don't actually go to the pharmaceutical companies. They go through them, all right? The 13 largest pharmaceutical companies paid over $150 billion to pharmacy benefit managers, suppliers, and providers in the US as rebates. And here's what I'm talking about, okay? So this graph shows you from 2010 to 2017, the total revenue of the 13 largest pharmaceutical companies in the world. So total revenue is the top line. Pharmaceutical sale revenue is the second line, and some of them, sell other things like consumer products and what have you. Surprisingly, the graph is rather flat. Okay, pharmaceutical companies have not been growing in recent years, not very fast. Yes, they have huge profits, but their overall growth has been stunted considerably by the fact that they're losing so many brand name patents. Okay, but if we break this graph into revenue from the United States versus revenue from the rest of the world, okay, the red line with the triangles is the revenue these 13 largest pharmaceutical companies have made from every other country in the world outside the United States versus the blue line, which is the United States alone, okay? And as you can see, by 2016, the lines were actually crossing, meaning that the 13 largest pharmaceutical companies were making more money, slightly more money from the United States alone than from every other country combined. But the yellow line is what you really have to concentrate on. The yellow line is the rebates and chargebacks that they pay to pharmacy benefit managers, suppliers, and providers, okay? And what does this do? Well, when they pay 40%, and I should say, the blue line is the money that the pharmaceutical companies had left over after they paid the rebates. So basically, the pharmacy benefit managers get this bribe from the pharmaceutical companies to include certain brand name medications on their list. Well, the more expensive the medication, the higher the rebate. They want higher rebates, right? And so in order to keep the rebates going up and up and up, to continue, getting their drugs listed, the pharmaceutical companies pay higher and higher rebates and thus have to make up for it by raising the price. It's basically a legalized system of bribery. So you purchase a $400 inhaler, for asthma at a pharmacy. Obviously, if you have good coverage and it's on your, and it's an approved medication, maybe you pay a $20 copay for it, if you're lucky. The pharmacy benefit manager compensates them for the rest of that money, right? But then the pharmaceutical company pays upwards of 40% of that, $160, in a rebate back to the pharmacy benefit manager that they get to pocket. And this is what's causing the skyrocketing of medication costs in our country, at least for the brand name medications. All right, it's simple math. Higher priced drugs yield higher rebates. All right, and just again, for a comparison, this is the revenue of the 13 largest pharmaceutical companies, quite flat. These are the revenues of the largest pharmacy benefit managers. Just from that growth curve, you can kind of tell who wears the pants in that relationship, who is in the driver's seat. It's the pharmacy benefit managers who are encouraging, driving higher pharmaceutical costs. All right, so summary for the medications. The high prices of brand name medications are largely driven by the perverse incentives among those most responsible for choosing which medications we can purchase. Okay, still 87% of medications prescribed in this country are generic, and most are far less expensive than most people would guess. So eliminate pharmacy benefit managers and rebates, you knock 40% off the cost of medications in this country in one fell swoop. All right, also always check the price of your medication. Your copay could be quite a bit more than the medication actually costs. Check it on GoodRx. And if you're buying insurance coverage for a medication that costs next to nothing without that money, why do you even need that coverage? Okay, switching gears. Medical billing. Have we got a deal for you? All right, about 8 years ago, I think y'all remember on Time magazine, there was this article called Bitter Pill, which featured a whole bunch of outrageously expensive hospital bills. I felt at the time, I was doing my research, that a lot of details were kind of missed in this story. And so to revisit that, I'd like to show you some outrageous hospital bills, okay? We'll start with one that I really love here. This is for a patient who got sinus surgery as an outpatient procedure at Pacific Surgical Center, outpatient surgical center, all right? And it was about a 1-hour procedure. He checks in early in the morning, he checks out before noon. Okay, now the important thing to look at here is the total amount billed. $97,140 for a procedure that barely lasted an hour, all right? But the other important thing to notice is the discount on that bill, which is the next line, $92,687. In the end, his insurance, Cigna, paid $3,562 for his procedure. He paid another $890 for a total of about $4,450 total was all that was paid on this procedure that was billed at over $97,000. Now, I'm sure someone's going to ask me along the way, well, what happens to that other $92,000? Nothing. It never existed. It's like asking what happens to Santa's elves after Christmas, okay? Santa Claus doesn't exist, neither do these billing charges. And that's something you have to keep in mind. So roughly 5% total was ever paid on this bill by anyone to anyone. Next bill. This is for somebody who was actually hospitalized for 3 days at Altabates Hospital in 2014. Okay, now you're looking at it, the total amount billed, okay, was over $126,000. I know you need to put on your reading glasses for it, but it's $126,714. Again, almost the entire bill was deducted in what they call patient savings, the next column over. $107,000 completely disregarded. Okay, how much was paid on this bill of over $126,000? Just over $19,000. In other words, Bates Hospital billed this patient's insurance company roughly the price of an Audi convertible. The insurance company returned with roughly the price of a Honda Civic, and Bates said, okay. The rest of the money disappeared, was never paid by anyone to anyone. But notice in this case, 15% of this bill was paid as opposed to 5% in the last bill. Here's someone who was a bit sicker, hospitalized for 10 days in 2014. In this case, and he was in the ICU. In this case, the billing charge, total charges there towards the bottom of the very first column to the left, $367,000. That is a lot of money. But in this case, they're calling the discount adjustments. I circled that. Adjustments, $264,000. Again, most of the bill. The insurance paid in 3 payments this time for reasons I don't know, but still, they paid $10, then $68,000, then $34,000. In other words, just over $100,000 plus an extra $100 from the patient. So just over $100,000, or 30% of this bill, was paid on $367,000 in billing charges. You following me? Let's go to the next one. 2-day hospitalization at Stanford Medical Center. 2 days. She had abdominal surgery, released, admitted on July 25th, released on July 27th. Okay. $91,578 billed. In this case, the discount isn't nearly so generous. It's only $36,600. This time, the insurance company agrees to pay 60% of this bill for a 2-day hospitalization. So you get 5%, 15%, 30%, 60%, and this one. Guy has a little dust up on his motorcycle. He tips his bike. The ambulance takes him to the ER. They say, you're okay. They dust him off. They send him home. The bill, $16,231. Inexplicably, the insurance company agrees to a more than $11,000 payment on that $16,000 bill and tells the patient he owes them $3,500. For reasons I can't imagine, the insurance company agrees to pay 93% of this bill. 5, 15, 30, 60, 93. You're finding that confusing, I know. But believe it or not, I don't think you're quite confused enough. And so to remedy that, I saved the best 2 bills for last. You ready? Okay. First patient got a hysterectomy at Bates Hospital and has United Healthcare as her insurance. Second patient got a hysterectomy at Bates Hospital and has United Healthcare as her insurance. Okay. Both patients get their insurance from work. Both patients are middle-aged. What was the difference? First patient had it done as an outpatient procedure. Okay, she was home by noon the very same day. Checked in the morning, checked out that morning, was home by noon. Second patient, a little bit more complicated. It was a 3-day hospitalization. She had some recovery time. Okay, both approved well in advance elective procedures. All right, both in network. As you might expect, Bates Hospital billed United Healthcare quite a bit more for the 3-day hospitalization as they billed for the day procedure. Okay, they billed $86,000 for the 3-day hospitalization, whereas they billed only $41,000 for the procedure that didn't require any hospitalization at all, where she was home by noon. But for reasons I can't imagine, United Healthcare agreed to more than $29,000 in payments for the day surgery, or 70% of the bill, whereas the 3-day hospitalization, they only agreed to, you can see there on the bottom, United Healthcare paid $10,153 and the patient paid $2,788. So just under $13,000 was paid for the 3-day hospitalization by United Healthcare to Bates Hospital, whereas over $29,000 was paid for the procedure that didn't even last till noon. What are we seeing? Absolute chaos. And this is what you need to understand. Hospital billing charges are complete works of fiction. There's no other way of putting it. Not only that, payments have very little to do with the actual billing charges, And they also have very little relation to the medical services provided, even by the same insurance company to the same hospital. You think I'm exaggerating? This was sent to me a few years ago. I'm a single practitioner, okay? It's just me, all right? This is Blue Shield of California telling me the range of payments one insurance company will pay me, one doctor, in a single year for the exact same services, okay? Hospitals, a large hospital provides as many as 10,000 services, okay? They see several thousand outpatients a week. They deal with dozens of insurance companies. They have absolutely no idea how much they might get paid for any given medical service from any given insurance company on any given day. It's really that arbitrary. Those bills prove that, okay? So why is there such rampant overbilling? Well, hospitals have no idea how much they'll get paid, so they set this arbitrarily and insanely high price on every medical service they provide. They take what they can get, 5%, 30%, 80%, pick a number. And that's how it's done. And people don't realize that's how it's done because it sounds too crazy to believe, yet it's what you're seeing. Now, within chaos, you can see certain patterns. This is from CMS data based on just about every hospital in the country, all right? So it's about 5,800 hospitals throughout the United States. Total billing charges is the blue bar. This is the total amount nearly all hospitals in the country sent out in total billing charges for absolutely every service they provided, inpatient, outpatient, the CT scans, ER visits, everything. The green bar is how much they got in total payments, all right? In other words, by 2015, hospitals in the United States got an average of about 28% on what they billed, okay? Mostly because of the discounts, adjustments, and patient savings that you saw on just about every bill. In other words, they billed over $3 trillion, got paid about $800 billion on all of those billing charges. Okay, and this is basically the same data from a separate source, the Office of Statewide Health Planning and Development in California for all California hospitals, just to show you that I have multiple sources for the same information because it looks so crazy. All right, and this is from the American Hospital Association showing why hospitals put up with such a crazy system. Since 2012, they've had an average 8% profit margin. Okay, in other words, they're getting paid very well to ignore this randomness. Okay, when you're getting paid a lot for something, you tend not to ask a lot of questions, and they're not asking a lot of questions because it's working for them. I mean, they took a hit during the recession, of course, but they've made up for it since then. All right, and you might want to know more than 80% of hospitals in the United States are still nonprofit. Okay, so why do the insurance companies encourage such chaos? Well, just like with medications, if you never know how much a service is worth, then you never know when you're being overcharged for the service. And that's really important. Case in point, 2012 Los Angeles Times, okay? This is a woman who gets a CAT scan of her abdomen at a hospital in Long Beach, right? Billing charge for that CAT scan, outpatient procedure, $6,707. Well, Blue Shield got her a great deal, 67%. She was on a high deductible, so she paid the entire amount of over $2,300. And then she thought, wait, that's a lot of money. And so she calls up the hospital and innocently asks what the cash price of that CT scan is for the uninsured. And lo and behold, just like for generic medications, the hospital said, yeah, we'll do it for $1,054. In other words, the deal Blue Shield got her, which was a 67% discount, was more than twice what the hospital would have given her for just picking up the phone. Why? Well, it's her money, and it's fun to spend other people's money. This is from the Wall Street Journal in 2016. Melinda Beck did a really good expose, throughout the United States, showing multiple examples of hospitals willing to give people cash discounts that are less than what their insurance, the deal the insurance would get them for the exact same procedure, usually if they're on a high deductible. All right. And so again, trusting the insurance company to get you the best price on any service in medicine is grossly misguided. But people don't realize that. They always assume that the insurance companies will use their power, their size, and their negotiating skills to get the best deal. It's usually wrong, okay? And we're going to discuss why in just a couple of minutes. All right, do you need insurance? Of course you do in this country, because you'd be stuck with those bills on your own. And most of the time, the hospital, you're lucky if they give you a 50% discount, and then you're left with half that enormous bill to pay entirely on your own. So yes, you do need the insurance, especially, you know, if it's emergency care, because you don't have any negotiating, you know, skills when you're taken to the ER in a coma or anything like that, right? So obviously you need insurance. And this brings us to one of the main reasons insurance companies like overbilling and encourage overbilling so much. In the United States, insurance companies are more of a protection racket than a service. In other words, they are less about paying for needed services as they are about protecting you from fictitious overbilling. You want to go on it your own without us? You're stuck with, you know, half the bill, 3/4 of the bill, all on your own, and it's insanely high. And those bills are really scary. So what this does is it obligates us to use insurance for every medical service, no matter how trivial, because those billing charges prevent us from paying for it on our own. And what this does is it prevents us from understanding how much any of this should cost. And this is why there's such a huge disconnect, you know, even among many of the people who work in this field, between what they think it ought to cost and what it actually costs. I mean, imagine, you know, you get a fender bender with your car, right? You bring it into the shop and, you know, the mechanic there says, oh yeah, that's going to cost you. It's, you know, it's going to be at least $300,000 to fix your bumper. Oh wait, the insurance company got us a deal. It's only $50,000. You'd say, wait, that's a 2012 Toyota Corolla. I got it for $25,000 brand new. No way it's $50,000 to fix the bumper. You can do that with your car. But there is so little understanding of how much generic medications or CT scans should cost, or, you know, hysterectomies in this country. And these, not only these billing charges, but the payments on the bills are so insanely chaotic that people have simply lost touch. And the insurance companies hide behind this. And also, they serve as gatekeepers. Instead of rationing scarce and expensive resources, which is what they're always telling us they're doing, they actually make their money by bottlenecking goods and services that ought to be inexpensive, as you see constantly, okay? They aren't just, you know, they say, oh, we're being fiscally responsible, okay? We're making the tough decisions. You shouldn't have that test. Now, if you think the test is $5,000, that sounds more reasonable than if you know the test is $300, right? I mean, if you think that goods and services are 5 or 6 or 10 times more expensive than they really are, then suddenly the insurance company's, you know, parsimonious behavior seems reasonable. Just like if, you know, Patricia Bernstein thought her medications really were $1,500 rather than $40. Okay, suddenly it seems reasonable for the insurance company to not want to purchase the medication, right? It gives you this illusion. But what the billing charges also do is they allow the insurance companies, just like the pharmacy benefit managers, to deliberately drive up prices in healthcare to increase their overall revenues. It works through what's called the medical loss ratio. You've probably all heard of it. And you say, okay, well, that's a good idea, right? Insurance companies are obligated to spend 80 or 85%, depending on the type of policy. You know, they're not always obligated, but they usually do stick with a medical loss ratio of 80 to 85% of all of their premium revenue should be spent on healthcare expenses. That sounds like a good idea, right? Because it makes it look like they can't have these huge overhead costs wasting your money. Unfortunately, since they are able to pick and choose all of their own prices in a system where almost nobody ever knows what anything should cost, you know, and here's a graph which basically shows that most of the insurance companies stick with that. What they do is they keep their margins tight, okay? This is the average profit margin, okay, for the 7 largest health insurance companies in the country. And you notice it's a pretty tight 3 to 6%. They're not huge. They're comfortable. They're constant, they're comfortable, they're not huge. But you got to ask, 3 to 6% of what? Okay, because 3% of $100 billion is a lot more than 3% of $20 billion. And by the time you get to 3% of $500 billion, you're talking some serious money. In order to keep their revenues climbing, I mean, in order to keep the profits climbing, they just have to keep the revenues climbing. And when they can write their own ticket by determining the price of everything, they can continually and persistently drive healthcare prices up by paying more and more and more. And they have these huge billing charges to provide them cover. Okay, is a 67% discount on your hospital bill a good deal? Well, not if 90% is closer to the right price, right? Or 95%. You don't know. And if you don't know, they can hide behind that. And this, again, explodes one of the biggest myths about health insurance companies. We always assume they are about saving money. They are about being parsimonious. They are about making the tough, fiscally responsible decisions. No, they're not. They're about squandering money like drunken sailors, and while at the same time making it look like that's what they're up to. And this is why they throw so many barriers in front of people. It's like they want to prevent you from getting this, that, and the other thing because, oh, it's too expensive. Not telling you that most of the time it isn't. And so here's what the MLR misses. Health insurance companies are required to spend at least 80% of their premium revenue on healthcare. They're not required to spend that money wisely. Big example. So from the Office of Statewide Health Planning, and Development, what I did was I went all the way back to 1995 for pretty much all the hospitals in the state of California. And I compared how much Medicare, Medi-Cal, which is California's Medicaid, and private insurance companies spent per inpatient admission. All right. So for every inpatient that either had Medicare, Medi-Cal, or private insurance, how much was spent by each of the entities, right? Excuse me. So you can see in the 90s, the private insurance companies, Medicare and Medi-Cal, pretty much, traded places. It was relatively even, about $8,000 per patient, okay? But since 2000, when the health insurance companies started discovering that, profit through squandering, they started paying more and more and more relative to Medicaid and Medi-Cal. Now you got to think, Medicare covers the elderly and the disabled. Medi-Cal covers the impoverished. Who ought to cost more? Who does cost more? It's the opposite. The private insurance companies are spending far more per hospitalized patients, even though on average they cover the working well. And here's the same data for each and every outpatient visit. Okay, each and every outpatient procedure provided by hospitals, Medicare, they're paying, by 2016, they were paying almost twice as much for hospitalization and for outpatient service as the private insurance companies. Why? They want to. Drives up the revenue. They can only drive up the revenue through driving up their costs, and the billing charges give them all the cover in the world to drive up those costs. Okay, now, I'm sure some of you are thinking, no, that's not what's going on. What's really going on is these big, huge hospitals are pushing around these poor little insurance companies. Maybe you're not thinking that, but even if you are, I'm about to destroy that myth, okay? The single largest hospital conglomerate in the entire United States is Hospital Corporation of America, okay? They run more than 174 profit hospitals in this country. Most hospitals are nonprofit. The majority of hospitals are still independent, are still relatively independent. I mean, even giant hospitals like Cedars-Sinai, okay, are single independent entities. If you compare Hospital Corporation of America, just in terms of total revenue, to the largest insurance companies, Okay, and keep in mind, Hospital Corporation America is about twice as large as the next two hospital conglomerates. Okay, and it's slightly bigger than Cigna. Then this was in 2017. Cigna's grown since they bought Express Scripts, but it's dwarfed by the largest health insurance companies: United Healthcare, Anthem, Humana, Aetna, all much bigger. In fact, United Healthcare has nearly 50 million members, which is almost as many people as Medicare insures, about 56 million members. So to even imply that the insurance companies are being pushed around by the hospitals, no. The insurance companies know they can grow their revenue by paying more, and the hospitals aren't asking any questions because nobody ever complains when they're getting overpaid. And so you see costs skyrocketing, revenues skyrocketing, profits skyrocketing, and we in the United States pay twice as much as the rest of the developed world for our health care, with poorer outcomes to show for it. And they say, what are you going to do? Look at those bills we have to pay, even though for the most part they don't. So in conclusion, health insurance companies, just like pharmacy benefit managers, benefit from higher prices, and the outrageous billing charges and chaotic payment system give them a huge amount of cover to raise their costs at will. Okay, so the entire myth of the parsimonious insurance company that's always making the tough decisions and denying health care because, oh, we've got to save the money and we've got to be fit, that is a complete snow job. It has nothing to do with reality any more than the myth that all prescription drugs in the United States are expensive. All right, questions? Anything? Anyone?
Wow, thank you, David. I think we need to take just a second to process that a little bit. Wow.
Yeah, I had to talk rather fast. I have so much stuff to go over. I didn't know what to leave in, what to leave out, you know. I wanted to keep it, you know, under 50 minutes.
Right, and nine years of studying this, you had a lot of material in there. Thank you so much. And thank you for
I didn't even cover health insurance companies. That's where the sparks really fly.
And thank you for your energy, because you made this presentation really easy on our ears to listen for this long after we've already heard Edward earlier this evening. So I'm taking a look to see what we have for questions. I see Joanne and Corinne have questions. So Joanne, if you want to go first, unmute yourself, and Corinne, be ready to jump on after her.
I was going back before Dr. Belk made his presentation, and the discussion about the messaging and communications. I'm an elected official, and so the first time I brought up single payer healthcare, I could not get a second person to second my motion to advocate on behalf of the borough. 3 years later, I tried it again, and this time I used the argument, the economic argument, that it would save the taxpayers, the borough, the school districts, and us. Overall, we ended up with a unanimous vote. So the economic argument seems to work much better at the political level than some of the other arguments that we've been using in the past.
It may have also made a difference that you were talking on a local level. David, can you chat with us on that a little bit about using the information that you've shared to make political change?
Well, I think my primary goal, of course, has been to define the problem. I mean, I say this till I'm blue in the face that, you know, you shouldn't be trying to solve a problem until you fully understand it. And so I'm really in the business of, this is exactly what they're dealing with. This is who's taking advantage of us. And I'm more about pinpointing, you know, well, in what I presented tonight, obvious cases of fraud that should anger people. And then once you've defined the problem, once you've, you know, cleared the smoke screens, it seems a little bit easier to come up with solutions. And you know, one of the issues that I like to bring up here, again, with these outrageous billing charges, these outrageous, list prices with, the pharmaceuticals. If you think you're talking about paying, 5 times as much as you're really paying, reform is always harder to bring up. Nobody wants to talk about that much money. And then suddenly when you break it down to, by the way, this is all that's paid on it. By the way, the insurance companies are pushing it. Then suddenly it becomes, oh, we can do that. I mean, just, in terms of, your own personal finances. If remodeling your house costs $400,000, you're going to be a lot more hesitant to do it than if it only costs $4,000, right? Money matters. And so it's incredibly important to dig down into this nitty-gritty and see where exactly the money is going and how they're manipulating you. And this allows you to take control of the message, because it's not a $300,000 hospital bill you're asking the patients to cover. It's not, it's far, far less than that. And of course, the fact that, Medicare is now on average paying, hospitals about half as much. Now, that becomes kind of a difficulty, because if you cut the hospitals off too much, too quickly, you may run into trouble. I mean, I've always argued that you're better off unwinding this money and making sure you understand all of the finances before you start ripping things out. Because yes, about $1 trillion is wasted in our healthcare system. Unfortunately, a huge amount of that $1 trillion is being spent in ways that are totally and completely untraceable. That would be, the subject of the third part of my lecture, or the third part of my book. If anyone wants to buy it, it's available on Amazon, by the way. A single payer is obviously a potential solution. It's not the only potential solution. I mean, I hate to say that. I know I'm committing heresy by saying that, but, come on, get rid of the pharmacy benefit managers. You knock 40% off the cost of prescription drugs, okay? You expose all of the finances in healthcare, okay? But you have to expose all financial transactions so you see exactly where the money is going. And then you come in and you say, okay, this is where the fraud is. This is where the fraud is. I mean, people talk about, the margins on the top, that's peeing in the ocean. All right. The real money is being wasted on the fraud, and the real fraud is occurring in financial transactions that are untraceable to anyone, mostly between employer-sponsored healthcare plans and, the providers. And this is what needs to be exposed, okay? Until you expose everything, you're kind of in the dark about the exact problem you're solving, okay? Yes, single payer is a very, very effective healthcare system. We know that. It works in the UK, it works in Canada, it works in Australia, but implementing it means unwinding all of what's going on in our current healthcare system. And that needs to be, it's kind of like you have a patient who, medical example, comes in with a cancerous tumor. The tumor is bad, you have to remove it, but any good doctor is going to tell you, you don't just cut it off with a samurai sword. You have to go in and look at all the places, all the ways that it's affecting the person. This is the same with healthcare. We have so many financial transactions about which we're not aware of. And the ones we are aware of, the conflicts of interest and the fraud, and it's easier to eliminate them once you've exposed them, which is what I'm doing.